Hello, my name is Seena Fazel. I'm a forensic psychiatrist. I've been working in medium and low security and also in prison mental health over the last 20 years, and more recently working in a community forensic mental health service. I'm speaking today on research in risk assessment and some clinical implications. And I do so as a clinical academic. I've been doing research in this field for the last decade or so, and we've been working and developing some novel ways of doing assessments that we think will improve clinical outcomes and more and also importantly sort of improve efficiency in how these things are done. So I'm going to share my screen and hope this works. Um, Let me do the sharing again. Sorry. Here we are. There we go. I'll put it on slideshow mode. There you go. So yeah, that's me. So what I'll do today is talk a little bit about new methods. Um, I think the whole perspective here comes from what's happening in the rest of medicine, which is about which I think we can summarize as predict and prevent. So if you can predict things, you can prevent them. And it's often the difficult question in lots of medicine is who are the people that you see that are going to have the poor outcomes, and therefore who are the people that you need to focus the limited resources in intervening and managing their risk going forward. I'm going to present some of the models we've worked on called the Oxford models. I'm going to present one in some detail, which is an example really of all the other ones. And finally, some clinical implications to take forward for those of you, involved in service management and actually working clinically directly with people in forensic services. I start off with a little bit of an example locally. So I work today. I'm in Warneford, and I put up a Q risk. A Q risk is a risk calculator for cardiovascular risk, 10-year prognosis. So looking forward over the next 10 years, what's the chance of this particular person who lives in this area, who's a 40-year-old woman with some family history, but otherwise very few risk factors. And their 10-year history is 1%. So that means one person with the same background characteristics in 100 will experience a heart attack or stroke in the next 10 years. And so 99 people with a very similar background will not. And that can help you think about what to do next. And particularly if the next person you see in your clinic is an older man from a Pakistani background who's also got a family history, but also doesn't have many of the other risk factors that the Curious tool has studied and identified. And here, the probability of this person is almost 1 in 5. So it's approaching 20%. It's 18.4%. So 18 people like this individual will get a stroke or a heart attack in the next 10 years. Now, you're going to do something, I think, quite differently in terms of your risk management going forward based on this assessment. So you've got an assessment of someone who's 1%, and the following person has got 18%. I think you almost certainly will offer this 18 person with 18% risk a statin, and you will give them some more information, and probably already had some on dietary changes and lifestyle changes, exercise. The 1% person, you may not do anything differently. I mean, you may just say to them what the risk score is, and just encourage them to keep up, to keep fit and healthy as per usual, but nothing additional to what they're already doing. But for the 18%, you will do something different. And this is part of the sort of perspective of predict and prevent, that here we've predicted something differently using a sort of consistent, transparent and evidence-based approach. And that's led to a different prevention approach. But in mental health, we have a bit of a problem. We don't have tools like this most of the time. We've got different tools. They're often developed for different outcomes. In forensic mental health, they're mostly developed for crime outcomes, which is sort of okay. But if you look at suicide research, and I mentioned here the suicide tools, they're not validated for suicide outcomes. They're often checklists, like a depression rating scale, but they're used and I think misused for suicide outcomes. And most of these tools, they have a lot of false positives, and they also have this issue that a lot of the people that experience the bad outcomes in the future, the poor outcomes in the future, and the low risk groups are identified as low risk. So there has been a problem, and on the basis of this, NICE and other guideline committees have been quite cautious about the tools, at least for suicide. In forensic mental health, it's very different, and they're used as part of a sort of holistic approach to assessment that involves individual factors and risk formulation. But the tools are part of all that process. So you've got this sort of weird situation going on in mental health where you've got a different set of advice for suicide than you do for forensic outcomes, although actually the same issues apply to both. In the rest of medicine, though, I mean, I think people have moved on, moved well beyond this simplistic way of looking at these tools, and they have developed tools which are scalable, simple to use, a bit like the QRisk, and for different outcomes. So here's one for diabetes medicine. It's this is at a primary level, primary prevention level, a secondary prevention level, and they give you risk scores, and they can be translated into probability scores. But they're simple. They're well evidenced. They're developed on large data sets. We have them in renal medicine as well, respiratory medicine. This is a preoperative risk. This is used preoperatively to help plan treatment after an operation for lung disease. This is a melanoma risk calculator, again, at the primary prevention level. You know, what's your risk of skin cancer? And again, it's a simple calculator used, and NIH recommend its use. And you can get very low scores. So the idea that the rare events can't be predicted is just not true. You can predict them quite accurately, as long as you have good quality research to support it. So the key features of these tools and the rest of medicine is they're sort of simple, scalable, transparent in terms of, you know, what goes into them, you know, what effect they have, so you can see the effects, the risk factors, the effect sizes, or the effects of these different risks. And they're free to use, and they're online. And they've been developed using very large population data sets. And one of the methodological advances is just how people develop these tools using the best standards now, which are about pre-specifying all of what you do, and following statistical methods, which again are pre-specified and clear and being validated in other settings. Avoiding subjective categorizations like low, medium, and high based on just sort of subjective views on reading, thinking about a few risk factors. Avoiding additional interviews because you want to sort of reduce resource implications. Using probability scores. And categories can be added. So the QRisk, for instance, recommends 10%, but I'm not going to do something differently if someone is 11 or 9%, I don't think, or 10.1% versus 9.9%. The categories, up here are not very fixed, like they are if you use high, low, medium. Here you can see a probability score, and you can make sense of that much more if you do have a recommended category. And they can be varied according to clinical context, because in some places, you might actually have a slightly higher threshold for where you're going to act differently than another context. And this is a little bit to do with how you test performance, but I think I won't talk about that today. And you see a lot of people have been talking about this way of doing prognosis, where you model probabilities a bit like weather. The weather app on your phone doesn't say yes, no, it'll rain or it won't rain. It'll give you a percentage score. And I think when you get lots of high quality data, when you bring together large electronic health records, you can do this quite accurately for diagnosis and prognosis. You don't want this is Frank Harrell's famous statistician. You don't want the classification measure, which is yes, no, high, low. You want a probability score, which gives you something you can work with more flexibly. And other statisticians, Richard Wiley's a professor of stats here, said this also, that risk estimates are really the way to think about these prognostic models, these models that try and help you think forward about people's risks going forward rather than these simplistic yes-no tools. So we've been developing tools based on these methods and this approach using probability scores for outcomes in forensic psychiatry. So this is a tool for people in general psychiatry to model violence risk, and this is a tool in forensic psychiatry on discharge from services to again model risk in the next year, and it gives you a probability score. And then we've also developed a couple of tools which have been validated externally for suicide risk, and this is completed suicide. So a rare outcome, but a very, very important outcome, obviously, to prevent. And they're all available on our website, Oxmith. And what we've done to develop these tools, we've gone to the best-in-class country to develop these models, which is Sweden, because Sweden has these registers which have been in existence from the 70s onwards, which are very high quality, which are linked across different databases and linked very accurately using 10-digit personal identification numbers. And they can enable you to do this type of development and validation of so for Oxmith, the tool we developed for violence in people in general psychiatry, we used a sort of large sample of 75,000 people who had over 500,000 episodes of healthcare, and looked at developing or deriving the samples. This is for the suicide study, but it's the same applies for the violence study in half the population, validating it in it's over half, and validating in a different geographical region. And using different methods. So this is an example of the tool for the Oxmith, where you've got drop-down menu. It's got 14 items, and at the bottom is a probability score. Here's Oxmiz, which is the suicide tool, and here you can see the probability score. And it cuts out for suicide at over 5%, because after 5% it becomes a little bit unstable. With Oxmiv, it cuts out at over 20%. So this is not, these aren't tools that give you very high scores, but because most of the risk is actually in the lower end of the spectrum. An important part of our work is to validate it in other data sets. So we validated Oxmiv in Oxford in first episode, and that's where we think is a very good use of the tool. When people are first presenting services, they have a comprehensive and holistic risk assessment that includes all sorts of other risks as well, including relapse and self-harm and suicide. And here's a couple of other validations. So in summary, I mean, we've developed these models which provide probability scores. They provide accurate stratification of risk. Everyone has a risk, so one of the good things about them is they sort of underscore the importance of safety planning and further, particularly needs assessments in this population. And there isn't a low risk paradox. So that actually in our tools, the low risk paradox doesn't really apply, because you can use these probability scores rather than just a simplistic cutoff. Do they have a role in clinical practice? Well, I think so. And I think part of it is to do with the fact that everyone has a score, like I mentioned. And part of it is that, what you do about these assessments, these other assessments, like needs assessments, has to be informed by risk, because clearly you're going to do something differently if the risk is much higher in somebody. So you're going to do, for instance, that man I showed you with a very high cardiovascular score, you'll treat his needs very differently. So if he's got, let's say, a particular need around another healthcare issue, that will be dealt with your perspective will be very different. It will be informed by risk than someone with very low risk. And in mental health, that will also apply. There will be risks, there will be needs which aren't necessarily directly related to risk, but what you do about them will be informed by risk, because there's only so much you can do And the sorts of things are about referral to other services, how frequently you do follow-up, medication review and optimization, multidisciplinary team meetings in people where the risk seems higher than you would expect. And importantly, in going forward, an area of increasing interest is collaborative risk assessment. So these tools, because they're transparent, they're simple, and they're scalable, you can actually complete them with people and their carers, and that in a way gives them a sense of sort of ownership and understanding also of the risk factors that are involved and how they can modify them. Other approaches. So, I mean, what could you do if you don't use these tools? Well, you could just not do them and just use clinical experience. And the problem there is that we know that there's a lot of biases involved. People, clinicians are often very optimistic. There's also a lot of problems with consistency and transparency when that happens. Because you don't like someone, you might give them very high, might say they're very risky. Or if you don't have much experience in it, you might actually make it, not really understand the importance of certain risk factors. And you want to really have a consistent way of doing it in order to communicate. But also, I think, to underscore importance of resource allocation, can't give everyone everything. And so you do need some defensible and evidence-based approach to do this better for a team. Another approach has been, and this is somewhat been said in risk for suicide, is just do a needs assessment. Don't bother about risk. Because we can't really do risk very well. Well, first of all, you can, we've shown that you can do risk assessments well if you use these prediction models. And actually, but what you do about needs assessment will have to be informed by risk. So if you see someone who self-harms, and you see two people who self-harm, and one is someone at a much higher risk population than someone who isn't. What you do about that particular need, and maybe let's say about alcohol misuse, will be determined by that risk. I think quite importantly, because there's only so much resources in the community to deal with alcohol misuse. And then other people have argued that you can use this tool to screen, and it's sort of like a triaging instrument. And now machine learning is a big area, but there's problems there about how you interpret them because it's very difficult to interpret them and their transparency, and then how they can be translated into NHS systems. So in conclusion, I think novel tools can be used to improve assessment. They provide a level of consistency and transparency, which is really quite positive. They can raise the ceiling of expertise, particularly in teams with a lot of turnover, a lot of new staff. And you can see them as part of a sort of wider holistic risk management, that the assessment is part of this bigger picture. And have to be embedded alongside clinical practice because there will always be individual factors that have to be considered and will be really important to consider. And overall, I think they're part of, like I say, a wider holistic risk management. So anyway, thank you very much for your attention, and I'll be happy for any of you to follow up by email. Thank you. Bye.